So the study from the Cleveland Clinic, which is featured in this Journal of American College of Cardiology, is very insightful on the management of carotid artery disease concomitant with coronary artery bypass surgery. And I think it will open up some questions, and also, more importantly, it will really drive the idea that we probably need a randomized controlled trial, blinded, that will allow us to really answer this instead of based on retrospective studies that we've currently looked at, including the one from Cleveland Clinic today. But however, based on the studies that we have just recently published in JACC, this is a very insightful study that will, I think, increase the activity of carotid artery stenting in a staged procedure prior to open heart surgery. And I believe that this is one of the first times that we've actually had a very nicely done study that actually looks at the time period between the actual intervention in the stage category, the staged carotid treatment, followed by open heart surgery. The concomitant procedure with carotid surgery performed at the same time under the same anesthesia as a coronary bypass surgery, I believe, does have a higher stroke rate, and consequently should be only performed in those patients who have the need for urgent or coronary bypass surgery specifically that cannot wait for the time period in the staged procedures. One of the things I do want to highlight, however, is that there were 14 days in the patients that had staged carotid endarterectomy to open heart surgery. There were 14 days in between that time period, and there were almost 47 days in the staged carotid stenting prior to open heart surgery. And I think that this does also call for us to decrease these time periods, especially in the carotid endarterectomy open procedure, than what has normally been performed. For instance, at Emory University, we allow usually 1 to 2 days, usually 2 days between the open carotid endarterectomy and the coronary bypass surgery in the staged CEA group, not the 14 days. And we saw a lot of patients in this Cleveland Clinic trial that had events of stroke, but more importantly, death and myocardial infarction, waiting for their open heart surgery. So I think that time period needs to be reevaluated. In the patients who had staged carotid stenting to cardiac surgery, that's obviously obligatory secondary to the Plavix, the need for Plavix to wear off, or let me rephrase that. In those patients who had the staged carotid artery stenting followed by coronary bypass surgery, specifically, there was a 47-day delay in the open heart surgery. And this is required because the patients are on Plavix, which consequently is initiated for 3 to 4 weeks. It is stopped for roughly 4 to 5 days, and that leads to the 47-day time period. So that is obligatory, and that is necessary. But I think that during that time period, we had the Cleveland Clinic group showed a 5% mortality. And I think that number needs to be decreased, and we need to reevaluate that time period. I do believe that the current paper from the Cleveland Clinic regarding the treatment of concomitant carotid artery disease and open heart surgery will change physician practice. I foresee an increase in the use of carotid artery stenting in a staged fashion prior to open heart surgery. However, I do believe that we need to be careful about the mortality that occurs in that time period between the carotid artery stenting and the need for open heart surgery, in the sense that there was a 5% mortality during that time period. And I believe that that needs to be further evaluated into the aspect of why these deaths occurred and how we can prevent these deaths. I do believe that that the time period for those patients who had staged carotid endarterectomy should not be 14 days, as was seen in the Cleveland Clinic group, and that should be a shorter time period. I believe that will decrease the 24% myocardial infarction rate that the paper has shown us. I do believe that those patients who had combined carotid endarterectomy had a 7% stroke rate which appears high in all aspects when you look at patients who've had combined carotid and coronary bypass surgery specifically. Therefore, this leads to some limitations to this current manuscript, although it is quite impressive with their results with the staged carotid artery stenting. One limitation is that the majority of the patients were performed for the open heart surgery were on pump, meaning that they were done with a cardiopulmonary bypass circuitry. It's possible that during that time period, the data is we're unclear of the data whether an epi-aortic ultrasound was performed during the open heart surgery to grade the ascending aortic atherosclerosis, which we know is a high source for embolic disease and causing perioperative strokes. I think also that the study spans from a almost 25-year time period, and of course the treatment of patients was quite different in 1997 as it is in 2013. So we need a little bit more contemporary medical therapy and also contemporary techniques. Also, as you note that approximately 80% of patients had in the carotid artery stenting group had a filter placed for protection and embolization. This is now much more common, and consequently we would expect the patients to do better after carotid artery stenting. So overall, there are limitations to this paper, but it opens up and it really begs our societies, the cardiologists and the surgeons, to do a randomized trial looking at the benefits of carotid artery stenting or carotid endarterectomy in those patients who have concomitant coronary artery disease specifically, and also those patients who have carotid artery disease, which is greater than 80%. Thank you.